Good morning, everybody. Thank you, Mr. Chairman, for the kind introduction. So we will deal with stroke mimickers in this lecture. So this is the format. So we will start with some definitions. So stroke mimickers are something that is well defined in neurological papers as a non-vascular condition that present with the clinical symptoms like stroke. So it's basically used for clinical settings, but we can also use it for imaging settings. So this represents the false positive cases. We have another group, which are the stroke chameleons, meaning strokes that present with other strange clinical presentations like seizures or movement disorders or intracranial hypertension. Here we are going just to deal with this, first overviewing the clinical mimickers and then just picking some of the imaging mimickers. So we are actually going to talk about mainly non-vascular conditions that will present with an acute neurological deficit that are not an arterial ischemic stroke, nor a transient ischemic stroke, nor a subarachnoid hemorrhage, nor an intracerebral hemorrhage, nor a cerebral venous thrombosis. So what are actually we going to talk about? So in the emergency room, if we take just the clinical presentation of the patients, we will have up to between 13 to 30% of stroke mimickers. And this will depend if you are working in a department with a stroke unit. It tends to have a more precise clinical evaluation, then the number is a little bit lower. But if we had imaging to the diagnosis of these patients, the number of stroke mimics gets much lower. It will go into 4 to 6%. If you use just CT, whether if you use diffusion and MR, as we have seen in the last talk, you actually go down into 1% of the mimicker. So the first thing is actually that imaging has done a good job in ruling out stroke mimickers. So in a clinical setting, the most common ones are obviously the functional neurological symptoms, so the psychiatric disorders, the converters. And then we have seizures, and this is challenging, and post-ictal paralysis, migraine, and many metabolic conditions, mostly hypoglycemia, that, however, it's very easy to make the diagnosis on the lab. But yet there is a tremendous number of other causes. We are not going to able to cover all of them, just going to pick one or two that from the imaging point of view may be helping you when you are reading the studies. So let's start with the three most common ones. So hypoglycemia, I mean, you just look at the analysis of the patients and you make the diagnosis. But if your clinician didn't ask for the glucose levels, these patients generally present with a decreased level of consciousness. But sometimes they can present with acute neurological deficits. And they are generally reversible if you correct the glucose level. So these two cases provided me by Professor Mauricio Castillo show you neonatal hypoglycemia with bilateral necrosis of, in this case, occipital and also parietal lobes because it was more extensive. And in this case here, the missing cortex sign with bilateral infarctions. Another case with a more atypical presentation with bilateral lesions of the white matter. But generally what you see, and sometimes you just see them on the subacute phase, is the cortical necrosis that tends to be bilateral, but it can be asymmetric, as you see here, with cortical necrosis and with enhancement of the cortex. So by parietal occipital cortical necrosis should prompt you to the possibility that somehow in the process of this disease, of this patient, could have been a hypoglycemic event, especially if we are dealing with children. So, but the challenging cases sometimes are the seizures and the post-ictal state. So we know that we have the post-ictal paralysis, the so-called thought paralysis. It's rare that you have inhibitory seizures, meaning seizures that course with loss of function. So most common presentation will be hemiparesis after tonic convulsive general seizure. And we are going to gather all the changes that we can see as the transient periictal MRA abnormalities. So this patient was coming off the time for IV treatment, and he was having a right upper limb paresis. And when you actually see the MR on the top, the flare image, on the bottom, the diffusion images, you see that you have a cortical subcortical lesion, hyperintense, over the motor area. And if you look carefully, actually you see that the cortex have some restriction, and the subcortical white matter has vasogenic edema. And actually, after the clinical follow-up, the patient was, again, having motor seizures, and with the control of the seizures, everything went away. But one key point here is when you see this and they resolve, you should always look for an underlying pathology that is causing the seizures to the patient. So these transient abnormalities are generally reversible by definition. They occur during the acute phase or immediately after the seizure. They are more common associated with status epilepticus. And remember, there are non-convulsive status epilepticus that can clinically mimic stroke. And they have not a vascular distribution nor arterial distribution. They are related to the epileptic focus. So another patient presented in the acute neurological deficit, but this is easy. So this you see that this patient has a tumor, so another stroke mimicker. But if you look careful, the cortex is swollen. Well, you could argue maybe it's infiltration of the cortex. And you would, when you see with gadolinium, you see that actually the PL enhancement was associated, extended far beyond where you think that the bulk of the tumor was. You do the ER diffusion, and you clearly see that the cortex has restricted diffusion well beyond, on the ADC maps, well beyond the tumor margins. And you do the perfusion on this patient, and this corresponds to an area of increased CBV. So this mismatch between decreased ADC values and increased perfusion should prompt you to the possibility that you are dealing with seizures. And on the follow-up, you control the seizures, the cortex has come to the normal, and of course the patient has the tumor beneath. So these lesions are generally hypointense on T1, hyperintense on T2. They may have cortical enhancement or PL enhancement. You will have cytotoxic edema. And a pitfall would be that if you have cortical cytotoxic edema with subcortical vasogenic edema, think on the posictal abnormalities. Spectroscopy will give you also a lactate peak and a decreased NAA. And on perfusion, you may have two phases. You may have an early phase of hyperperfusion with an increased CBV and decreased MTT, or you can have the opposite. So you can have a perfusion mismatch like in a stroke, in this patient with a decreased CBV and an increased MTT, so mimicking a stroke. So it's important to remember. Migraine is another challenge, especially if it's the first episode. If you don't know the patient has migraine, so it may account to up to 10% of stroke mimics, especially two groups, hemiplegic migraine and migraine with aura. And you also have these transient migraine abnormalities, which can also cause with reversible cytotoxic edema. And on perfusion, this is there is a huge controversy regarding pathophysiology of migraine, but let's put it easy. So when there is the aura, which means loss of function, you will have a decreased perfusion, so a decreased CBV and increased MTT. And when you have the headache following the aura, you will have an hyperperfusion, okay? A simple way to remember. Of course, these patients you also have, during the aura period, they have a decreased metabolic rate of O2, because actually they have this spread of cortical depression, mainly the opposite of a seizure. In the seizure, you have an excitation of the neurons. Here you have actually an inhibitory spread. But some of these patients, I'm going to show you one, may have actually a migrainous infarction. How do we know? Because the aura didn't resolve. So these patients continue to have the same deficit. Let's look at one example. So this patient, we knew that they had a migraine with visual aura, but actually this time the headache was different. It was associated with a more prolonged, more intense aura. And on the early CT, you could actually see that you see a lesion on your occipital lobe, hypointense cortical subcortical lesion. You do your MR study, you are no doubt that you have a restricted diffusion here, cytotoxic edema, corresponding to the T2 images. So you know that there is a lesion, but you also know that the cytotoxic edema in migraines may be reversible. Although in this patient it was not, and you look at the MRA and you see the abnormalities that you sometimes see in these migraine attacks with multifocal areas of stenosis. And indeed, although some part of the lesion was still reversible, there was a scar and a permanent neurological deficit. So then from the other group, I will just want you to talk you about maybe the signs of transient global amnesia and some metabolic stroke. So transient global amnesia is a neurological condition where there is an antegrade and retrograde amnesia that can last for 24 hours. There is also large speculation regarding what is the etiology of this. Can we help? Yes, we can help. And if you do MR, in some of the cases, you may depict abnormalities. Sometimes not in the conventional images, which is difficult to depict. But if you do a thinner slice of diffusion-weighted image on axial and coronals, and you take some attention to the hippocampus, you may see actually abnormalities, as you see here, and on your magnified view, that you have a very small area of cytotoxic edema on the hippocampus. So what can you see on MR on these patients? Well, the exam can be completely normal. You can have transient abnormalities or permanent abnormalities. And what are these abnormalities? They can be diffusion restriction at the hippocampus or diffusion restriction plus T2 signal modification. What about metabolic stroke? This may be important because it's a mimicker for children that present with stroke. And let's speak about MELAS, mitochondrial encephalopathy with lactic acidosis and stroke. So typically when we see a lesion that may be multifocal affecting the basal ganglia, the thalamus and the cortex, you should think on the possibility of mitochondrial disease. In children, it might be easy, but sometimes you get these patients also in adult age. And you see this lady was 27 years old, and she was having a fluctuating evolution of global aphasia. And you see the MR, you see multiple lesions, bilateral, cortical, as you see, some of them very tiny. And when you look at your diffusion-weighted images and ADC, they did not seem to have the occurring all at the same time. So you had mostly vasogenic edema with some small spots of cytotoxic edema. So you do the perfusion on these patients, and the perfusion you can rule out an arterial occlusion because they will not show you in the acute and subacute phase decrease of the perfusion. In this case, it's an arterial spin labeling imaging, and what we are looking are for CBF flow parametric maps. So the MELAS will actually involve into 4 phases. In the preclinical phase, we will have an increased CBF due to the metabolic abnormality that you have. Then you may have structural changes, and those are going to be detected by diffusion-weighted imaging, and you can have everything. You can have restricted diffusion, or you can have cytotoxic vasogenic edema. On the subacute phase, the CBF will start to decrease, and on the chronic phase, generally, you have a scar from permanent lesion. So you have to remember that with mitochondrial, we are not looking to the problem of the arteries, we are looking into a defective metabolic pathway. Well, if we gather now just not only non-vascular conditions, but also vascular conditions, we don't have time to cover this, but cerebral venous thrombosis Either dural sinus or cortical veins are a great mimickers. They can present in many different ways, and we unfortunately have no time to cover this. Then, of course, AV fistula, malformations, aneurysm, cavernomas can also mimic strokes. I would like also to draw to your attention to two other situations that may help you in your daily routine. One is PRESS, more known, and the other one, it's a group, a miscellaneous group that is grouped in the reversible cerebral vasoconstriction syndromes. So PRESS, you know, they are associated with, firstly, with hypertension, then with eclampsia, preeclampsia, but there are many other situations, clinical situations that may be associated with PRESS. So this is a abnormality of the vascular regulation, autoregulation. What you have is generally a hyperperfusion, and you will have a vasogenic edema, typically affecting the posterior areas and the watershed areas. And you do your diffusion, and generally what you see is vasogenic edema. So this is the typical findings, but you should remember that it's not only posterior. You can have anterior located, even basal ganglia and posterior fossa, and you may have hemorrhage in a small amount of cases, as you see here on the cerebellum, and it's not always reversible, since you may also have areas with cytotoxic edema. Well, this is a challenging group, and this is a challenging diagnosis. So this is a group of conditions, and you can see here many of them, different names that you can find in the literature that are gathering because they are presenting with vasospasm, not associated with subarachnoid hemorrhage, not secondary to subarachnoid hemorrhage, better to say that, and they are typically reversible. And this may allow you to make the differential diagnosis from vasculitis. So the clinical presentation in almost all cases will be a thunderclap headache. So they will mimic from the beginning a subarachnoid hemorrhage. The imaging of the brain may be completely normal, structural, and just to see changes in the vessels. You can have a PRESS-like vasogenic edema. You can have infarctions. You can have cortical, isolated subarachnoid hemorrhage, especially in young people. You should remember this possibility, and intracerebral hemorrhage. What you see on the images is actually vasospasm in out of context of aneurysm rupture subarachnoid hemorrhage that is multifocal, large and medium-sized arteries, and that is reversible over the next month. So let's look at one case, more severe case. So this patient was operated for a nasal tumor on late phase of post-op. She developed this tremendous vasospasm bilaterally of the carotid arteries, MCAs, ACAs, basilar, PCAs. And actually, some of the lesions have evolved into brain infarctions. How can you make the diagnosis? Because you treat the vasospasm, and on the follow-up, everything on the vessels return to normal, although, of course, the patient had a scar due to the infarction. So about stroke mimics, we could pick any sign of stroke and go into the differential diagnosis. I will just focus on two points that may be interesting for you, which are the so-called pseudo-penumbra, so other conditions that will go with increased MTT and normal CBV, and they are not resulting from an acute arterial occlusion. And one of the most common ones is artery stenosis, carotid stenosis, vertebral stenosis, basilar stenosis. So extracranial or intercranial stenosis may present with an increased MTT with a normal or decreased CBV. So whenever you are looking at this, you should look at the vessels in the neck, you should look at the vessels at the skull base to see if there is a stenosis there responsible for this. This is a very interesting picture that I took from a paper because you see here that you have the infarction area, and over the infarction area you have two different perfusion patterns. In one, a clear area of increased MTT and decreased perfusion, and the other one was being reperfused. So the CBV was coming to normal, but with an increased MTT. But this is not a penumbra. This is an early reperfusion. And you can see this on early cases, as this one, and on old infarctions, you also can see this area of reperfused, generally at the periphery or at the margins of an infarction. But some other diseases can do it, like just venous congestion. So this another stroke mimicker. This patient entered the emergency room with an acute neurological deficit, and what he had actually was an acute subdural hematoma. Although he went all the process that we have for this, the stroke patients, and eventually got also a perfusion. And you see that you have an increased MTT over this area, but this is because you have a slow circulation due to the compression of the veins over resulting from the subdural hematoma. So simple things like this can give you a pseudo or false ischemic penumbra. And of course, if you are talking about the venous part, you should also think that cerebral venous thrombosis can also give you this type of images. And you see here that is a superior sagittal sinus thrombosis. You see the chord sign of a cortical vein thrombosis. And on this area of cortical vein thrombosis, you have an increased MTT with a normal CBV. So again, a different type of penumbra not related with an arterial occlusion. So then we have covered this. So seizures and migraine can have hypo and hyperemia. And remember this not as two moments, but this is a continuum. And look at this case. So this case, the patient started with seizures, and then he was on Todd's paralysis. And actually, no brain lesions could be seen, and you start to see an increased MTT before you see abnormality on the CBV. You still have some increased CBV here. So the patient is going from a hyperperfusion stage to a hypoperfusion stage. Okay, this is, you are more familiar. So you know that not only stroke can give you cytotoxic edema, and cytotoxic edema, as we have seen in the previous talk, can also be reversible. So briefly, there is a large number of causes of cytotoxic edema that you should remember. Let's see just some of the most common ones. So herpes encephalitis, you know, targeting the limbic lobe, can have also a cytotoxic edema on the pathogenesis of this infection. You can also have cortical cytotoxic edema associated with Creutzfeldt-Jakob disease, as you know, and this is make the differential diagnosis with cortical necrosis, but clinical context is completely different. CO intoxication, this is the typical images that you get, bilateral pallidal necrosis, but actually you can have delayed lesions on the white matter that also occurs with cytotoxic edema. You see on the first image, and then on the second follow-up study, you see the burnout of the white matter is completely destroyed, and you see high signal and diffusion with the corresponding low ADC maps. Other types of intoxication with heroin also can give this type of image. So then you ask the question, well, so we have stroke mimics, but we have to be counting with the time dart to needle to treat these patients. Is it safe to treat these stroke mimics? And people have looked at it. And because you are always going to have stroke mimics that are going to get IV thrombolysis. And the last paper that actually gathered a large number of patients, more than 5,000 patients, and it was published last year on stroke, clearly showed that the rate of hemorrhage in this patient is low. In stroke mimics patients, it's about 1 to 2%. There was no fatal hemorrhage in this group. And it was clearly much lower than the rate of hemorrhage, the brain hemorrhage, of course, associated with the real stroke patients. And this number, the hemorrhagic stroke on 1 to 2%, is more or less the same rate of hemorrhage that you get when you do thrombolysis for myocardial infarction. So what are actually the conclusions that we can get? So stroke mimics on the clinical side are almost 13 to 30% of cases. Neuroimaging has actually allowed to decrease this number dramatically, and this means that we provide a safer treatment if we do better imaging modalities. We have also our stroke mimics that we have to remember when we are dealing with this. And in the balance between treating a patient and making the evaluation if it's a stroke mimic in this balance, it seems to be favorable to treat the patients anyhow, even knowing that we are, at the end, going to try to treat some false positive cases. So thank you very much for your attention.